I'm very pleased that the Romanian Society of Obstetrics and Gynecology is the co-host, together with the Polish Society of Obstetrics and Gynecology, for this webinar concerning the screening strategies for preeclampsia in Eastern Europe and the prospects for better management. I will just talk shortly in a few slides about the importance of ASPRE study, aspirin for evidence-based preeclampsia preventions, about the findings and the day after in the preeclampsia management. The extensive research in the past 20 years, mainly as a consequence of the shift in screening for aneuploidies from the second to the first trimester of pregnancy, has identified a series of early biophysical and biochemical markers of impaired placentation. A combination of maternal demographic characteristics, including medical and obstetric history, uterine artery pulsatility index, mean arterial pressure, and maternal serum pregnancy-associated plasma protein, PAPA, and placental growth factor at 11-13 weeks gestation can identify a high proportion of pregnancy at high risk for preeclampsia. The study involving 58,000 singleton pregnancy examined at 11-13 weeks gestation has further refined the prediction algorithm for preeclampsia. Using this algorithm, the estimated detection rate of preterm preeclampsia was 75% at a false positive rate of 10%. Before we talk about ASPRE study, let us refer to what was done in practice historically. I will share some information regarding the National Institute for Health and Care Excellence, NICE, and AGOG guidelines at that time. As you see, it's interesting that none of the two ways of predicting preeclampsia was very effective. While NICE guidelines was giving a detection rate of almost 40% in preeclampsia before 37 weeks, this was not enough. Fetal Medicine Foundation, led by Professor Nicolaidis and his team, after several years of research with many data on ultrasound and biochemistry markers, have finally come to an updated algorithm that includes the basics of NICE guidelines, but update this with Doppler pulsatility index and biochemistry test. So the most effective algorithm that was chosen also for the ASPRE study screening part was the triple test. That means mean arterial pressure uterine, uterine artery pulsatility index, and placental growth factor, which has been proven to give a high detection rate for preeclampsia before 37 weeks at 77% with 10% false positive rate. This is the ASPRE study design. That means this protocol was published in 2016. It was performed, as you see, in 7 countries, starting with screening ladies on first trimester pregnancy based on the Fetal Medicine Foundation algorithm described previously. High-risk ladies were treated with aspirin at 150 milligrams at night from 12 to 36 weeks. The outcomes of the ASPRE study, it validated an updated clinical algorithm for screening preeclampsia and classifying women on high and low risk, validated the dose of aspirin that works very efficiently at high-risk women at a dose of 150 milligrams, validated the time and duration of the treatment, that means bedtime and starting from 12 weeks to 36 weeks, and proved that the treatment with aspirin reduces the rate of preeclampsia before 37 weeks by 62% and preeclampsia before 34 weeks by 82%. Irrespective of estimated risk and obstetric history. So, although treatment with aspirin is not a cure, however, reduced significantly the number of women who suffer from this pregnancy disorder. It's important to state that ASPRE has looked on the safety of the aspirin treatment by checking all side effects of this woman. It's very important to know that the efficiency of a treatment means also the compliance rate of this treatment. As secondary analysis of ASPRE study trial was the effect of aspirin on the length of stay in neonatal intensive care unit. And it was shown a bit later in 2018 that the prophylactic use of aspirin results in 70% reduction in the length of stay in NICU, mainly through prevention of early preeclampsia. What's next? What happened? The NICE guidelines were updated in 2020. A year before, the FIGO guidelines were updated accordingly. Our Romanian Society of Gynecology and Obstetrics updated the guidelines for hypertensive disorders in 2019 with this new data. So it's important to have a national screening program for reducing maternal morbidity and mortality and reduce the intensive care unit and NICU costs. But of course, this is not very easy to implement this national program, not even in Romania. But as you can see, the Romanian Society in his guidelines has all the data that was shown in ASPRE study. But how this works in Romania, I will leave Associate Professor Anca Panaitescu to show us in her next speech. Thank you.